Thank you, Dr. Treppo. So I just like Dr. Treppo said, I do take a lot of the really kind of crazy cases. So we're going to start off with that. So here I have this patient that I didn't meet till 2021, but I found her first x-rays that were done from 2012. And this, I'm not really sure exactly what happened here, but she already needed a posterior splint, so there has to be some sort of trauma there. I didn't really meet the patient until a little bit later. And this is what she looked like in 2021. And you can see that this is a totally different deformity, right? And I met her, I looked at all the x-rays, and so I got a little bit of idea from her chart about what had happened. She had had a previous ulceration underneath the first that was treated, and that eventually healed, and then she started breaking down in her ankle joint. This is what eventually happened, right? It went from something that was more superficial to something that went a little bit deeper. And this is really when I met the patient, when she started breaking down within this area. And she also had end-stage renal, and she was on dialysis. So she was also dealing with that. So, there's not a lot of people that would want to even touch this patient with all these medical issues. But this is what I saw when we got a CT and an MRI of the leg, right? You can see that there's something wrong there. The calcaneus is not underneath where it should be. So I knew that we needed to get something back on in appropriate alignment. And so, to me, when there's a wound there around the talus, I feel like that's already infected. So I'm thinking I'm not going to leave the talus there unless I want a recurrent infection. So we decided to go in there, resect, do a talectomy, put an antibiotic spacer in there, and then put a frame on it. This is not something that I want to put internal fixation on right away. So I use the external fixator as a trick to my bag of tricks in order to treat these patients. And this is what she looked like afterwards. And it was not an easy surgery because she developed, like most kidney patients do also, wounds, right, that were hard to treat. But she did really well with wound debridements and graft applications. She ended up doing well with those, and we ended up taking out the external fixator. And so what's the next step? As long as there's no infections, then it's internal fixation for me. And this is the way that I fixate them with my IM rod to make it a nice and solid bone. I wanted propriofusion, and it definitely did look solid, but she still ended up with some wounds that we had to heal to all of these places. And we did grafting, and we did not let her weight bear on them with the wounds present until they were completely healed. And as you can see, she did. And so there I am patting myself on the back, and I said, okay, well now we can weight bear on this. With a cam boot, of course, not with a regular shoe on yet. And so what ended up happening is that did not tolerate that IM rod, right? And so we ended up getting a CT scan to see what exactly was happening there. And you can see probably, there was a fracture through the calcaneus. And so now I'm stuck with something that looks like this. Is it infected? Is it not infected? I got to go figure out what it is. And so our next step was taking all that hardware out, of course, and then putting an antibiotic-coated rod, and this is what I do usually. And I would have also put an external fixator on this to just keep it stable, but you know what? We're going to try to let it rest for a little bit and then come back to it. So at this stage, how many would have just said, that's it? Go to the vascular doctor and amputate. Anybody? Okay, well, good. So what do you do now? Well, you have a big hole. It's possibly infected, right? You have IV antibiotics for 6 weeks, and you have this antibiotic spacer there for another 6 weeks. So, this is kind of like the protocol that we sort of did, right? I had my initial stage, infection control, debridement biopsies, use of antibiotic cemented spacers, my application of external fixator, molar biopsies, more antibiotic treatment, and then finally removal of external fixator, internal fixation, and do internal fixation if instability persists. So what I've done in the past is then, I put an antibiotic-coated intramedullary rod in there and just, pray for the best. But then you also have to sometimes make a bigger intramedullary space for that. So you're making a bigger hole in something that's already unstable. So for me, I feel like in one of these, when I have this kind of patient, I want bone and I want it from somewhere, right? And so another major problem is, with these cases, you have a decrease in hindfoot height and limb length discrepancy, and that can also cause increased pressure on the other side, like Dr. Lando was talking. And high rates of non-union. So different augmentation materials have been proposed. So for me, this talk is about using the fibula in order to fix these kind of situations, and why not look at this as another form of fixation. These are my disclaimers. And so these are our objectives, exploring the use of fibular autografts and other vascularized technique, and review the evidence-based outcomes. So this is something that I do see in a lot of the case presentations that we talk about during our journal clubs. And I see a lot of this for when you need a TCC fusion in the diabetic patients. And when it kind of just makes me think about it is when they have no history of having an ulceration on the lateral aspect, they still resect a large chunk of fibula and then they put internal fixation, right? Like that. And I kind of feel like that's a loss of bone. I can use that bone in order to get my fusion the way I want it. But what are the options out there if you can't do that? Well, there's femoral head allografts, right? You have, if the patient has a large segmental bony defect, you can use this. But radiographic evidence of fusions in those patients is low, right? In this study, they concluded that TCC arthrodesis using a femoral head allograft could be considered as a salvage procedure, but it's technically difficult and has a high potential of complications. So let's use, and usually it's just putting in dead bone into that area. And while you can fill it in with all kinds of bone cement or some other sort of biologics in order to help it heal, it's still very difficult. So your best choice is autogenous bone, right? Regarded as a reference standard for bone grafts, provides the specific elements necessary to generate and maintain bone in a scaffolding, which is kind of what we need for osteoconduction, growth factors for osteoconduction, progenitor cells, and osteogenesis. Where else can you get this from? Well, the Elliott crest. I'm not going in there and getting this bone, so I'm probably going to need some of my orthopedic colleagues in order to get that. However, donor site morbidity is also high, right? From 15 to 40% when the graft has been taken from this. And then there's the fibula, right? There's two articles here. There's a major source of non-vascularized cortical allografts, and it's generally used to fill in defects and buttress constructs in the form of a full-thickness cortical graft. And when harvesting from the distal fibula, there's almost no donor site morbidity, as long as it's not infected. But let's look at the literature of when they have used this bone as a part of the graft. So here we have one study out of JFAS 2014, 6 patients. Patients had failed TARs and traumatic telectomies. They did standard lateral approach, distal part of the fibula removed and cut into 4 pillars. So this is something that I've never seen before, cut into 4 pillars and then placed in there. Plus they put a bunch of internal fixation. Results, no non-unions, which is amazing. All fused, 1 patient needed hardware removal, but guess what? No patients with diabetes. Right? So this is the optimal patient, post-traumatic arthritis, are able to use the fibula and heal this. How about it being used as an intramedullary fibular strut grafting. So this is a study, 2012. Now this patient had diabetes and probably a failed ankle fusion. They did not mention whether it was from Charcot or not, but I can kind of inference that. Revisional fusion using retrograde intramedullary non-vascularized fibular graft. So they basically just cut the fibula and stuck it down the bottom to take up that space. So they had the patient achieve solid radiographic union and restoration of the hindfoot alignment after 33 months with no complications. That's great. It looks like an actual great fusion. Here's another study, another diabetic female used in the ankle as a primary fusion rather than revisional arthrodesis. So here they used it as a primary fusion, probably no signs of osteomyelitis, so not needed for that. And they also didn't mention whether the patient had a Charcot neuroarthropathy of the ankle to use this, or it was just from some sort of trauma. And then finally, Spencer Monaco, 2016 foot and ankle specialist, had two cases where patients actually had diabetes with Charcot foot, where they use that fibular onlite for that TCC arthrodesis, and they both ended up walking well. But this is what you get from these kind of cases, just case studies, a few, not really a lot of things that you can base your treatment out of. And even here, where they got great fusion, it still kind of looks to me like they have a little bit of a non-union in that talus and subtalar joint. But it really did work, according to that article. So does it really work? Well, here's an article where it says, maybe they don't see that it was as successful, did not improve outcomes overall using cancellous bone alone. But overall fusion success was very high, suggesting that bone grafts may not be necessary in many ankle arthrodesis cases where they just compare these two types of individuals. Again, in this one, no patients had diabetes or neuropathy. So then I looked into vascularized flaps, because we know that patients with Charcot neuroarthropathy, they have some sort of, or can develop osteomyelitis, and I believe that my lady developed osteomyelitis. So when do you consider using this? Well, patients, it has its own blood supply, the vascularized fibular graft, transplanted using microsurgical anastomosis. Osteomyelitic bone is considered biologically compromised. You have all those inflammatory foci surrounded by sclerotic bone, which is all that I see, and you saw that on the CT scan. So direct vascularization ensures not just graft survival, but functional integration of the control and infection control. And most of my patients are infected. But if you look at the literature on that too, here again, you have this sort of case where they use this, but again, no mentions of patients having diabetes with that, right? But they did get good fusion and hypertrophy. But something like this, I'm not going to do that, right? I'm probably going to use my external fixator. This is probably a little bit too high for me to go, so I'm looking more at the area of the ankle joint. Okay, so let me see. Okay. All right, and here you have one other article. Again, no patients had diabetes, but they used vascular fibular graft and they had actually good results, right? And the vascular anastomosis is typically end-to-end anastomosis. But again, me and doing vascular end-to-end anastomosis, I think I'm gonna need my loops and a vascular surgeon or a plastic surgeon in the case with me at least. So let's continue with our cases, and we'll just have three cases that perform. So this is the same lady. Here I am. I decided to use my fibula. So here I am in my second part of the case. I took up my antibiotic spacer. I did reaming through that. I took out my fibula, and then I placed it on there, and I placed the external fixator on. And sequentially, I did a little bit of just compression every time she came into the clinic. And this is how I prepped my fibula. Here you see I actually cut holes within it. I filled it up with a bone graft. And then I also drilled a hole through it in order to fill it up with bone graft, and then I inserted it into it. And This is how she looked like with the external fixator. And of course, with these diabetic patients, they look great in the beginning, and then it almost all turns to kind of shit. And so I did have to take out the external fixator in the clinic, and then I put her in a cast because it wasn't ready to come out yet. But she ended up doing really well, and she ended up having full fusion, as you see there on the right. And this is her. Let me see that. So we did do one of those flipper feet, right? So here she is moving her forefoot. She was able to do that. Here she is walking, and she also had Charcot-neuropathy on the other side, so she's actually wearing the crow boot on the other side, and she's walking with the surgical shoe on that lower extremity. And so she did really well, and that was the first time she was walking in 3 years. Here's one more case really quickly. Another person referred to me. This, again, I like to show the original x-rays before I treated them. And he ended up having sequential amputations of the lateral column. And so with that, I really hate this type of surgery. Sometimes it has to be done, especially if they have a lot of, osteomyelitis and several complications. And in this patient, he also had a little bit of a psych history, so follow-up was probably not the best. But this is what he ended up showing up to me with. And you can see that he has osteomyelitis of his ankle. So the other facility ended up doing this type of frame, and they put an antibiotic spacer in there, and this is kind of how I met him, with this frame on there. And so, I was thinking, well, what can I do with this? This is the other side, actually. He also had an amputation. So I ended up, after taking out the antibiotic spacer, I said, well, rather than put an intramedullary rod on him, right, why don't I then use my fibula? But first, I ended up debriding the ankle and putting that antibiotic spacer on there, and coming back before he left the hospital in order to do the second part of the case. And once again, I'm there taking out the fibula. I took out the antibiotic spacer, made sure that labs were appropriate. And with his psych history, he was also homeless. And so I wanted to do this before he was discharged from the hospital and then lost to follow-up, because I knew that if I did that, then he wouldn't really come. And so that's the antibiotic spacer being taken out. And I'm almost done. So there I am. I did the intramedullary rod into the area of the ankle. And he did have a wound vac in there. And so this is him with his external fixator coming back to clinic. And then, of course, this is like maybe a month later where you see all the pins kind of broken in that area. And so once again, in the clinic, we had to take out that external fixator, because if I let him go, then who knows when he'll come back and it'll be all infected or come to the ER. So this is me and my team, and we're there, and that's really how fast we do it. So here he is afterwards, and he looks really swollen. And we ended up casting him. But he did really great, actually. And this is him just months later. He was able to have a full fusion, and he didn't have to lose his foot. So this is another picture of the x-rays. And here he is. We did perform another sort of flipper foot, and he's able to move the forefoot and kind of, walk with it. We still got him an Arizona brace to be able to ambulate with. But then he said, my other foot has been really hurting, and I wonder if you can take a look at it, and we did. And so he ended up going down to the ER, and the doctor that was on call, performed an IND, and eventually he got referred to another clinic. These are the current x-rays that I see of his other foot. The foot that I did was within normal limits, and we got him an appointment to see me again, but he hasn't shown up yet, so who really knows what is happening with that. And then the last case, this is just a really quick one of a patient who was referred to me. Now, you know what happened here. Several debridements, right? Forefoot completely just dorsally dislocated, and she's still putting pressure on it. So she's still, it started with those lateral debridements, and it's turned into an ankle Charcot. Here she is weight bearing. And you can see exactly what the problem is. And if we keep doing lateral debridements, that is what she's going to end up with, just no foot and all displaced. So in her, I already had the experience of going through all the debridements, putting in an intramedullary rod and getting that non-union. I wasn't going to do that. I needed bone. I needed it fast. I decided to do this free vascularized flap into that area. So I took a wedge and I flapped it down. I left the perineal artery intact, and then I put internal fixation in there and external fixation in there. She was also minimally insured. I don't know how that really relates to, but she had to go home and she had to walk up 40 steps in order to get to her room. So we had to put an external fixator on, or it was not gonna survive. So this is her afterwards, after 12 weeks, and again, we ended up removing the X-fix within the clinic. And she did end up having some vascular complications to the small toe. We ended up casting her. And this is her recently last week, and you can see she's doing really well. All the ulcers have closed, and she is able to move the forefoot. So, and this is her walking. Again, she hasn't walked normally in years. That's her with a cam boot, and we're currently trying to see if we can get an Arizona brace. And this is her fusion site. So in summary, the fibula is a reliable salvage option. You have to consider using autografts or allografts. What are you going to use? Whatever it is that you use, make sure that you constantly follow the patients. And again, just with those patients, you're going to treat them, you're going to give your all, and you can still end up in heartbreak, whether they lose the other limb or they lose their life. So thank you very much.